Good evening. It's a pleasure to be with you. I think I was the last one to join the group, so sorry, Riccardo. I think I can claim I'm the youngest one, and it's an honor. I always admire your work, and now I can collaborate. It's really good. So I think the program was really well planned because after a long day, long hours, everyone tired. So I think let's see if I can stiffen you up. So. As Cynthia now knows, I'm not a PhD, so I'm a clinician. So I have really problems to understand some biomechanical concepts. So as I do, I'll try, since we're going to talk about some studies in progress, some things that we're developing, so some true biomechanics, I'll try to go really briefly about some concepts to put everyone in the clinical level. So the biomechanics, really simply, it's the results of the response of the eye that the forces applies to it. So these are the forces that apply into the eye. So if we have the shape that we have in our cornea, it will be related to what it's constituted and the force applied to it. So I have these two shapes, these two balls, they look the same, but they are really different. One is soft, one is stiff. So if apply forces to that, one will deform more than the other. And in the cornea, if you have a point of weakening, you're going to have a deformation under IOP. So this how shapes changes. So as clinicians, we are really used to evaluate corneal shape. So we know how to separate a pattern of a normal pattern, a disease pattern, but we also have objective indexes to help us in that. But this is not static, this is dynamic, this changes. So what is normal can be abnormal with time. And we have this, as Renato always says, we need to find this susceptibility before the abnormality happens. So this susceptibility could be the biomechanical weakening before that. So after an environmental factor, it could be eye rubbing. Renato has this awareness not to rub the eye, the Violet June campaign. But in this case, it was a refractive surgery in a normal case. And with a really low impact surgery that developed with post-LASIK ectasia due to a biomechanical weakening previously. We have a poster in that, so I invite you to have a look at that, where I'll discuss this case more in depth. So it's not a matter of having a good shape. We know what's inside. So we have, in order to be applicable in clinics, we need to measure it in vivo. So we have the first attempt to the aura, but it's in indirect observation. These parameters cannot be related to direct mechanical properties. We have now, more recently, the Brillouin microscopy, which is a direct measurement of stiffness, but it's just in a single point. And the problem is that the biological tissue is not linear. So the tangent modulus increases with the stress and the strain. So we need the full stress-strain behavior, not just a single value. Especially if we could get a single value to get the full curve, it will be even better. So to explain really simply what stiffness is resistance to deformation. It's related to two things: the material properties of the cornea and also the geometry. So this was a video. This was this tough guy, this white belt taekwondo, 7-year-old boy. It's my nephew. So he could break easily a balsa wood. So, but I'm sure that the tougher he is, the stronger his kick is, he wouldn't be able to break a concrete block, because one is stiffer than the other. So the material are different. So they will resist differently to the deformation. And also, if you have the same material, so if you have a thinner block of concrete, it will resist less than a thicker one. So that's how Corvis come into play, because it's an RPF tonometer. We can see the deformation, you know that. So it's measure IOP. And here's the story begins in our group in Liverpool, and it's really good, all the work that I've been learning with Professor Elshake, all the ideas that he come up to. So the initial purpose is to provide inaccurate IOP readings. And Corvis, as all tonometers, they are based in a simple concept. So if you apply a force into a ball or the eye, the amount of deformation that you get from it is related to the pressure inside of it. The problem is this is highly affected by the eye's mechanics. So if you have a small deformation, it can be through a large thickness or a stiff material, not just the IOP. And in the other way, if you have a large deformation, it could be because it's a small thickness or a soft material. So maybe it's not that related to IOP. So while a certain deformations gives a certain IOP, this can be several combinations. And it's really hard to separate IOP and stiffness. And here is how our group in Liverpool are trying to work. So if we can determine the IOP with little effect with corneal stiffness, and if they can be separate, can we measure the stiffness? So we're living in the post-millennial era, Generation Z, so we have computers to help us. We can do numerical simulations to that. So we can input the eye geometry, the IOP, we can input the material properties to that, we can simulate the Corvis in the computer, and then we can compare with the real deformation. Doing an engineering process, it's called inverse analysis, we can find as an outcome this correction of the biomechanical correction of IOP and the beta value. The beta value is a single value to express the full stress strain curve. So from computers, so we have the validations of these numbers that are still in progress, but we have some that were already published. So for the biomechanical corrected IOP, we have an experimental in vivo study. So let's see if we can get the true IOP. So we get some eyes that we set the pressure under a normal range from 10 to 13, and we compare the non-corrected IOP and the corrected for the biomechanics IOP. So in this range, we can see that the correct one was way closer to the true IOP. So less differences than the non-corrected one. It was also clinically validated in individuals to see if we're getting repeatable and reproducible results of this IOP measurement. So, and they are really good. They are under 1 millimeter mercury in the repeatability, around 1 millimeter of mercury in reproducibility, which are really acceptable range for clinical use. And in a scenario where you have a stiffening reduction, such as refractive surgery, we see that the non-corrected IOP, we measured lower values, and this because the stiffness is reduction, so the stiffness is playing a role in this measurement. And we take stiffening apart, these measurements are the same from the pre to the post-operative. And in the other way, if you have a stiffness increase, such as the cross-linking, we still have stable values between before and after the procedure. So the BIOP is something that we really can trust, that we're getting close to the true IOP measurement without the effect of corneal stiffness. The other part of the study is to see if we can get the true material properties of the cornea, the whole stress strain curve, which we call the beta value that Riccardo told us before. So the first, this value, it should be related to age. So in a study that we did from population from Rio in Italy, we see that there is a strong correlation with age, and it should be independent from IOP and from CCT, and it was. So we have lots of studies in progress. This is still happening. So how we can apply it clinically? So the first application that you can imagine is in refractive surgery screening. So if you can get a step back from the shape, so if you can say that this cornea, before it developed ectasia, if it has this susceptibility, if it has this fragility. But in those cases, unfortunately, to study them, we don't have the Corvis data because they were operated before the Corvis was launched. So we did a flowchart to try to overcome the absence of Corvis to get the measurement that Corvis could give us. So we follow this flowchart. We have the patient-specific information. We inserted this information to the computer, so we built an eye in the computer, and we did the surgery in the computer. Comparing with the shape of the post-operative, we can do by this inverse analysis process to find the true material properties of the cornea, which is the beta. It's something that the Corvis in the future will be able to provide as well. We have so far, it's a pilot study, so we have 4 cases of ectasia with 43 cases stable. And we can see that the lowest the beta is, the more to the right the stress strain curve is, so more soft the cornea is. So a stable cornea would have an average beta of 1 should be normal, below 0.5 should be expected to be a keratoconus behavior. And in the ectasia cases, they were behaving like keratoconus. They are soft corneas. We still only have 4 cases, so we cannot rely that still. We're going to trying to get more cases. They are really hard to get. Renato has this quest to get pre-operative tomography and post-operative. So we're getting more to increase this number and get more reliable results. Also, we can apply it in the surgical impact, the actual measurements. Mine is not that, yeah, it's the same as you, okay. So sorry for the format. So we have one-dimensional measurements. So we have the stromal, the PTA, the residual stromal bed. They are single point measurements. Recently, Damien Gattinel developed this 3D analysis to have the corneal volume, the PVA, but it's not related to biomechanics, so we can add the beta, the true biomechanics, the true material properties to that. So maybe a soft cornea won't be able to tolerate a big impact, a high impact surgery, but maybe if it's matched, it can take a surgery. So we can do individual indices, you can do individual impact for the amount of stiffness that cornea has. This is something for the future as well that we're developing. And also in the post-operative, because in the post-operative you have change in geometry. And all the current metrics that we have, they are highly dependent on geometry. But even though the geometry changes, the material properties remains the same. So we'll be able to differentiate a normal post-operative cornea where all the current metrics, they should be altered, but they are still normal, they are stable corneas. And also for in the future, we also will be able to customize the cross-linking treatment because we can go beyond the demarcation line. We can have a true meaning of what's happening to the cornea, of how much stiffenings that the cornea needs, how much stiffness that we achieve. This is also something for the future, something that we are developing. So some messages that we can take. So first we can determine these true material properties in vivo. And the BIOP is the closest estimation that we can have for the true IOP. So now I'm in Liverpool, so my heart is divided between real landscape, between the Beatles, between Garrincha and Firmino. But it's really good. Thank you.